fetal central nervous system anomalies. Now, the ventricular atrium is the most appropriate part of the ventricle to measure. And this is a structure which has many, many things to offer itself as the key structure in looking at the fetal central nervous system. First, it is a structure which is stable in size throughout the second and third trimester. The fetus is the most dynamic structure you will ever study in your life, and the fetal central nervous system is the most dynamic system within the fetus. Of all the things that you could observe within inside of the fetus during the second and third trimester, there is exactly one that is stable throughout that period, making it an age-independent measurement. It has an excellent position marker, the choroid plexus. So, on an axial scan, where the choroid ends and the fluid in the ventricle begins, that marks the position of the glomus of the choroid plexus. The glomus marks the position of the ventricular atrium. The walls of the ventricular atrium are reasonably perpendicular to the direction of beam travel, which means that they will specularly reflect, which means they'll be easier for us to see. Indeed, you can see that the medial wall is a better specular reflector than the lateral wall, and that is also highly fortunate. Visual assessment is easy. There is a natural relationship between the size of the glomus of the choroid plexus and the size of the ventricular atrium, such that the glomus will fill or nearly fill the ventricular atrium, and if it does, no measurement is required. That is a normal ventricular atrium. It is also the earliest to dilate, which makes it our most sensitive structure. Now, I know that when you are studying neuroradiology, if you are an obstetrical sonographer or sonologist that studied neuroradiology, you may remember your teachers telling you that the temporal horn is the earliest to dilate. Well, that may be true in children and adults, but I have detected ventriculomegaly in fetuses before there was a temporal horn. And finally, there are signs which help us to diagnose true positive cases and avoid false positive cases. Now I ask you, what more could you ask for from a single structure? There was a time in my career when the right portal vein was my favorite anatomic structure. It has been replaced by the ventricular atrium. In my early career, there was a very famous, in fact, the most famous ultrasonologist of that era used to introduce me at congresses by saying, our next speaker is Dr. Roy Philly, who parlayed the right portal vein into a professorship in radiology. That was not far from the truth. So you could well imagine that the ventricular atrium has to be a very special structure to have replaced the right portal vein in my heart as my most favorite anatomic structure. There will be times when you must measure the ventricular atrium. Here are the rules. We begin, it must be measured in a true axial plane. I'll tell you how to do that momentarily. Second, we want to measure across the posterior glomus. So we need to see where the choroid plexus ends and the ventricular fluid begins. That marks the position of the glomus. We want to measure across the distal glomus. We want to measure perpendicular to the ventricular axis. That means we must determine the ventricular axis and measure perpendicular to it. We do not want to measure perpendicular to the midline, as is the case with certain other ventricular measures. Finally, we want to place the cursors at the junction of the ventricular wall and the ventricular lumen. So we want to measure this distance, We do not want to measure that distance. To put this simply, we want to measure the shortest distance across the ventricular lumen at the ventricular atrium. So, once you're there, you have all of the rules. Remember that the wall of the ventricular atrium is ependyma. Ependyma is one cell layer thick, and while I have great respect for the resolving capabilities of ultrasound, it cannot resolve a one cell layer thick wall. Therefore, anything that you think is the wall of the ventricle is not the wall of the ventricle. Do not include it in your measurement. How do we know we're making our measurement in the true transverse axial plane? Well, we run into a problem here with in utero sonography because near field reverberation artifact causes us to be unable to compare symmetry of the brain as our certainty that we are looking at a true transaxial plane. Therefore, we must look at symmetry of the calvaria. The more perfectly symmetric the calvaria, the more certain we are that we are looking at a true transaxial plane. Again, I will point out to you that the medial ventricular wall is a better specular reflector than the lateral ventricular wall. And again, this is also very important to us and very fortunate. If you measure a large number of ventricular atria, you will find that the mean diameter is 6.5 millimeters, one standard deviation is 1.3 millimeters, and 3 standard deviations is 10.4 millimeters. We have tested and used 10 millimeters as the upper limit of normal. Why? Because I like round numbers, and I'm proud to say that most of the world uses 10 millimeters as the upper limit of normal for the fetal ventricular atrium. There is a lower limit, but it's only of theoretical interest to us because there are no diseases or anomalies of the fetal brain which produce a ventricle that is too small. In now enlarged prospective consecutive series totaling over 7,000 fetuses, the ventricular atrium was visible in 99% of the cases. So, if you're having a problem seeing the ventricular atrium, you're having a real problem. And you're not going to solve that problem by saying, oh, I'll look at the temporal horn instead. As I said, measurement is typically not required. And this fetus with unilateral ventriculomegaly is an excellent example. The upside ventricle is normal, and you can see that the glomus of the choroid plexus fills the ventricular atrium. No measurement is required. Whereas on the downside ventricle, you can't even see the glomus of the choroid plexus. Clearly, this is an enlarged ventricle. That is a normal ventricle. No measurements are required. The only reason you would measure this ventricle is to get an idea of the degree of enlargement, not whether it is enlarged. So here is Mrs. Smith. She comes for her sonogram today. You observe that the glomus of the choroid does not fill the lateral ventricle. You are obliged to measure the ventricle. You do 9.2 millimeters. That is less than 10, therefore that is normal. Now, I have been accused in court, under oath, of being a 10 millimeter absolutist, and I pled guilty as charged. I can assure you, in your lifetime, you will not meet another ultrasonologist who has thought more about or done more investigations of the fetal ventricular atrium than I have. And after many years of due consideration, I have become a 10 millimeter absolutist. What that means is that I believe that using 10 millimeters creates the most good while causing the least problems. I can assure you of one thing that I have learned in my studies that have set this upper limit of normal at 10. If you set any upper limit of normal, you can be assured of only two things. Normal patients will fall above your limit, and abnormal patients will fall below your limit. With that in mind, I have decided that using 10 millimeters as a cutoff is what I am going to do in my practice. Now again, notice that the medial wall of the ventricle is a better specular reflector than the lateral wall. And that turns out, as I've said, to be highly fortuitous. Why? Because we have a constant marker for the lateral wall of the downside lateral ventricle, and that is again the glomus of the choroid plexus. The choroid plexus is not firmly held in the ventricle. Therefore, from its position where it is tethered at the foramen of Monro, it must hang down under the force of gravity until it meets resistance at the lateral ventricular wall. Therefore, the lateral margin of the downside glomus of the choroid plexus always marks the position of the lateral ventricular wall. The upside ventricle, also acting under gravity, meets resistance at the medial, not the lateral, ventricular wall. As the ventricle enlarges, the choroid must dangle down until it meets resistance at the ventricular wall. When I originally described this sign, the dangling choroid sign, that was in a stage of my development as a prenatal diagnostician, where I considered that evidence of an enlarged ventricle. I no longer consider it evidence of an enlarged ventricle. What it does represent is a definite clue that we must measure the ventricle and compare the size to 10 millimeters. Now, I taught my early fellows this sign, and when they went out and studied the ventricle themselves, they did a study showing that if this gap is greater than 3 or 4 millimeters, then that is a sign of an enlarged ventricle. All of these signs are legitimate signs, and I am not trying to denigrate them. What I am saying is that after due consideration and looking at all of the evidence, I am a 10 millimeter absolutist. So here we have a nice example of the dangling choroid sign. The choroid tethered at the foramen of Monro hangs down until it meets resistance at the lateral ventricular wall, thereby marking the position of the lateral ventricular wall. Hopefully, you do not need to measure that ventricle to realize that it is an enlarged ventricle. That is the key observation. And again, it is not my intention to stop you from observing that there is a large posterior fossa cyst. Therefore, this is almost certainly a Dandy-Walker malformation, or from observing this high-riding third ventricle, so that you may know that in addition to the Dandy-Walker malformation, there is also a callosal dysgenesis problem in this fetus. If you made all of those observations, I am extremely happy. But my only requirement is you spotted the dangling choroid sign, you realized that a measurement was necessary to compare to 10 millimeters, but a measurement would have been a waste of time because that's obviously an enlarged ventricle. The only time the glomus does not mark the position of the lateral ventricular wall when the ventricle is enlarged is when the ventricle is simply so large that the choroid runs out of length before it reaches the ventricular wall and instead hangs like a bell clacker in that dilated ventricle. If that is insufficiently convincing to you, then notice that the choroid from the opposite ventricle has fallen through this fenestrated septum such that both glomera are dangling in the same ventricle. The ventricular atrium is the key to the diagnosis of fetal central nervous system anomalies. Let us return to our study of the 112 fetuses. In those 112 fetuses, the ventricular atrium measured greater than 10 millimeters in 99 of them, or 88%. So, looking at the ventricular atrium enabled us to identify 88% of these 112 central nervous system anomalies. Ventriculomegaly is the tip of the iceberg we seek. We are looking for this great submerged iceberg of fetal central nervous system maldevelopment, and ventriculomegaly is the tip of that iceberg. Why does it work so well for us? Because ventriculomegaly is the final common observation in three entirely separate pathologic developmental mechanisms. If the ventricle obstructs, regardless of the reason, the ventricle enlarges. If an insufficient amount of brain tissue develops, the body abhors a vacuum, and in the central nervous system, it fills in the vacuum with fluid, usually fluid in the ventricle as well. If a perfectly normal amount of brain tissue develops and then something comes along and destroys it, again, the body abhors a vacuum. It fills in that vacuum in the central nervous system with fluid, again, typically also fluid in the ventricle. So here we have a patient that has come today for her sonogram. Mrs. Jones, you note that the glomus of the choroid does not fully fill or nearly fill the ventricular atrium, so you measure it, and it comes out to be 11 millimeters. Are we going to ruin Mrs. Jones's day for one silly millimeter? And the answer to that is unfortunately yes. You may also observe this mild lemon sign. This is a fetus with a myelomeningocele, but my first clue that it was present was that mild enlargement of the ventricle. Here is Mrs. Johnson. She has come today for her sonogram. We see that the glomus does not fill the ventricular atrium. We measure it. Are we going to ruin Mrs. Johnson's day because of one silly millimeter? Unfortunately, the answer to that question is yes. This is not a very good day for Mrs. Johnson. Again, if you noted this high-riding third ventricle, you've already decided that this fetus has dysgenesis of the corpus callosum, and that is commonly associated with a variety of bad things. All right. The probability is tomorrow when you do your first obstetrical sonogram, you will not see an enlarged ventricular atrium. So what is the value of it? Here it is. You have just excluded all the cases of hydrocephalus, nearly all cases of brain atrophy, all the cases that I have seen in more than 35 years as a prenatal diagnostician. Most cases of the Dandy-Walker malformation, nearly all cases of holoprosencephaly, all of the cases that I have seen in more than 35 years as a prenatal diagnostician. All the cases of hydranencephaly, nearly all the cases of complete agenesis of the corpus callosum, a large number and percentage of the myelomeningocele cases, and nearly all of the encephalocele cases. So literally, an observation that takes you less than 2 seconds accomplished all of that for you.